Okay.
Is this going to be in Portuguese or English? What should we speak in?
English.
Okay.
English.
Thank you. That's good. That helps me.
Yeah, Portuguese, it's better for us.
But everyone in the chat can ask questions, you know, in Portuguese, in English, and we can, after your lecture, we can do like a free webinar, whatever you guys wanted to share.
Microphone off.
Yeah,
yes, I already put this for everyone.
Okay. During your lecture, Ike, I think it's a good idea to keep everyone with the mic off, you know?
Sure. Okay.
And
People can chat. Okay.
After that, we can chat.
Okay.
Sounds good. All right. Let's go.
Okay.
Okay.
Today, Ike is the boss here.
Yes. So in 3, 2. Okay. You wanna say something?
3, 2, 1.
Okay, guys. So we are here for one more Glaucoma Zoom webinar. Today is a special one with my friend Ike Ahmed from Toronto, Canada. He's going to share something about how I have maximized my results with MIGS and subconjunctival surgery. So Mike, it's a real pleasure to have you here. You're the boss now, man. Go ahead, Redskins.
All right. Thank you. Thank you so much, Alberto, and everybody here. I'm going to share my screen, Alberto. If you could maybe, there we go. Perfect. Great. So yeah, thank you so much for having me here. I was just recently in Belo Horizonte in November, and it was a great time. And I hope that I can share some more of our experiences. And let's make this interactive as we go along as well, because Alberto asked me to speak about just my reflections on optimizing our results with MIGS, and also I'd like to speak about traditional and also alternative subconjunctival surgery, because although we talk about MIGS a lot, we have not gone away from subconjunctival surgery at all. So I think it'd be useful for that. And I realize that there are people in this in the audience here who have a variety of experiences from Brazil and around the world, whether they have done new surgeries or not. And so I think we're still in a state of flux. I do want to, of course, thank my friend Alberto, who's we know is a very smart guy. You know, this guy's got so many degrees and masters and PhDs and this and that. But when you first meet him, you don't realize that, because he is so happy and jolly and warm. And that's the first thing you realize when you meet him, is how warm he is. In fact, when I came to visit, he actually organized, he said, Ike, let's do like a formal dinner together, you know, or something. He said, I said, oh, come on, no, let's make it very casual. People can relax and everything. So he basically had it in a skateboard park with the band playing and people eating and drinking and just having a good time. So that's the style he has. But behind that, there's a lot of brilliance in what he's written and his ideas and his theory, and it's great. Also, you see there's a lot of great colleagues of his in Brazil, and I don't want to name everybody because I'll miss somebody, but you know who you are here, and I'm sure we'll talk about you today, who have led the charge. And yeah, as I said on a previous webinar, I visited Brazil the most outside of my country. United States and Brazil are the two most common places I visit. So I really have a lot of great connection there. And although I can't visit, I haven't been able to visit. I was supposed to be in Brascars, but I couldn't make it, of course, with COVID. These things continue to keep us warm and close. And that's my city, of course, before COVID. And this is our team. I just want to just mention again that we are still the defending champions in the NBA. It'll look like we'll have a repeat again this year. So I want to just start, before I dive into glaucoma surgery. I want to make a few points, and I'll pause a couple of times because there's a lot of stuff to talk about, and I want to make sure I emphasize what I think is important. Now, I'm going to mention a couple of things. First of all, number one, what I say is not always right. I make a lot of mistakes and I make assumptions, like I think most people do. Number one. Number two, I try to be credible despite working with many manufacturers, and I have a conflict of interest. I really hope I come up with an attitude that is fair and balanced and has ethics. And number three, I'm generally an optimistic person and a positive person. So I try to move forward and progress despite challenges we have. And so that's important. I also am somebody to kind of make sure we ask ourselves why we do what we do. And it's exactly this stuff here, which a couple of Brazilian colleagues include in here, that speak to the fact that we still have problems treating glaucoma. And that's the first point. Like, why do we have all the new surgeries? Well, because there's a need, there's an opportunity. We're not doing great with our approaches, whether they're diagnosis, whether it's medical therapy or whatever we're doing in this. And I think we should also be careful. We don't paint everybody with a wide brush. You know, glaucoma can present very differently. And in my opinion, there are two groups of patients that are not well served by how we treat glaucoma. Some of you here are on the call are interested in glaucoma, I know, and some maybe are just kind of curious. But I think it's important to know that that when we look at populations, we have to make sure we don't just make them all the same, and they're not. We have patients who have mild or moderate disease who are on medical therapy. They have problems with adherence, quality of life. The impact of lifelong drops is not to be minimized. And these patients have problems as far as their quality of life and the progression and the risk as well associated with that. But we also have a problem on the other side, people who are really bad, where our usual surgery, being a trabeculectomy, is maybe not the most standardized surgery, maybe not the most safest or predictable. And these patients have significant risk whether we do surgery or not. And we try to make it better for them. Now, this is, of course, leading to my premise, which is at this point in time, elevated pressure is an interventional problem. It's a philosophical point. I want to make it clear, I didn't say that glaucoma is a surgical problem or interventional problem. I said elevated pressure is, because I think that we know that glaucoma in the future and even more recently, we are looking at it from different ways, whether it's with neuroprotection, vascular, genetics, all these things that have to be considered in there as well. So when we think about, procedures like MIGS and subconjunctival MIGS, we can look at it as either something that replaces medications or something that lowers pressure a lot, right? A lot, like meaning down to like 10 or 12. It's important we don't try to confuse them, because too many people try to confuse them. We also need to remember, and I know that it may not be as interesting for some, but quality of life is why we do what we do. And we need to think about it from the patient perspective. Patient-reported outcomes nowadays, I think, are becoming more important finally. And we cannot just base it on IOP. I got a pressure of 10, I'm happy. Well, if the patient has 5 diopters of astigmatism and they have a watery, tearing eye and they're uncomfortable and they can't go out, well, you know what? Have we really done the best thing for the patient? If we're putting patients on 5 different molecules and to lower pressure and their eye is red and they have to wake up every day and put the drops in 4 or 5 times a day and wait 3 minutes, 5 minutes apart and everything else, have we done a patient a good service? If the patient's living in fear of going blind and anxiety around it and depression and everything else, have we done the patient a good service? So we have to think about not only the disease, but the treatment we have. And in fact, when you think about the effect of quality of life, the treatment we give to the patient, think about it, actually has more impact on the patient's lifetime than actually the disease itself, because the disease for the most part is essentially an asymptomatic disease. So we actually create more quality of life problems by doing our treatment, which is traditionally medical therapy. And the impact on the ocular surface, the impact on the conjunctiva and the cornea are all well described. And nowadays we have many patients who are very concerned and upset, for example, about our most common and most effective drop, the prostaglandins, about the impact on that. Now, for many of us, we say, well, listen, we're preventing you from going blind, live with it. And I understand that premise, but really, I think we have to challenge ourselves and to do better. And again, the effect of topical therapy has been described in the past, all the different impacts that we don't necessarily think about as clinicians. And we know even if the drop is fantastic, that compliance is a problem. I mean, let's just admit it, compliance is poor. And also the perceptions of our patients are also not great. We ask our patients, do you have any problems putting drops in? Do you miss your drops ever? Do you touch the eye with the bottle? Well, most patients will say they do a pretty good job, but when we actually observe them, when they're recorded or when we have ability to monitor them, that our patients are really not perceiving what's going on here. And when patients are not adherent, then they get worse. So that makes sense, but we have good data to kind of support that fact that patients can get worse. And this is really what the idea around interventional glaucoma is. And I want everybody who hasn't heard me to speak about this to remember that for us glaucoma specialists, I know that we're all nowadays on our phone and we're all on Instagram, which has been great to be able to share in things. I'm just, checking out my Instagram feed right now, right? But IG to me though is more meaningful in terms of interventional glaucoma because this is a different mindset. And before I get into how I maximize surgery, this is why I want to share these points, because I want to really share that it's the mindset, it's the attitude that has to first be present. And if the attitude isn't there, and if we're not on the same page, and no matter what I say, you're going to say, Ike, that doesn't make sense. I disagree with you. I don't like it, which you still can say, of course. But if you understand where I'm coming from, and some of you already, I know many of you are already doing these things, maybe you can appreciate what I mean by that. There's a couple of facts that are important. Number one, even with mild disease, and I really am disturbed when people say, this person has mild glaucoma, they don't need a low pressure. Is that really true? Now, depending on the age, of course, depending on the history we have, that may or may not be fully accurate. However, we do know that even with early glaucoma, that over a longer period of time, that if we keep the pressures down at 15 or lower, these patients generally have less chance of progressing. Now, they may progress slowly, maybe we don't worry about them, but let's just state the facts here from the Canadian Glaucoma Study and other studies, that even with mild disease, and patients that have high pressure glaucoma do better when pressures are kept at a lower level. So maybe 20 is not the best number. 21 was the old number. Then it was 18. Maybe we need to be more aggressive. We also know that simply adding medications isn't always the answer. That simply adding 3 or 4 or 5 more drops, does it really make a difference clinically? Well, some of the studies that are done, not the best designed that we have to answer this question, but adding a 3rd or 4th drop doesn't often help the patient. Maybe it helps us because we do something. We feel like we're writing something on paper. But does it really lower the pressure if you actually follow the patients and do it properly and account for compliance? Not necessarily. We do know, again, going back to the fact that lower pressures tend to stabilize visual fields. This is not from the Canadian Glaucoma Study. This is from the Advanced Glaucoma Interventional Study. And these patients had more moderate to advanced disease. This is where, of course, many of us came up with numbers like 18, et cetera, to be lower for patients with more moderate disease. But the reality is, again, getting low helps. And certainly getting to the patient earlier, which is part of the premise of interventional glaucoma, we can get a greater impact on the patient over a longer period of their life if we intervene early. And this is kind of the premise around the interventional glaucoma concept, where lower is better, earlier is better. We address adherence, but we have to do it safely, because if we do it unsafely, we're not going to be willing to do surgery earlier. And this is kind of the mindset of MIGS, where safety is important. And we have had some MIGS procedures that have been taken off the market because they weren't safe, or they weren't felt to be safe, I should say. And this is why we have to have a much higher level of safety than we do, for example, for tubes and trabs. And just a very easy way to divide them up. This is a slide I've made many, many years ago, and I've changed it over time. But we have our, conventional outflow, and we have our superciliary non-conventional outflow. For all intents and purposes, when I say MIGS, I'm basically referring to these procedures within the eye. And we don't really have suprachoroidal procedures available commercially anymore. So really MIGS right now is trabecular meshwork bypass, okay? Which is either by different approaches we'll talk about. And then we have conjunctival surgeries, which you can argue, Ike, is that really MIGS? And really there are differences, of course, with these procedures than traditional MIGS. But I put it in here because I kind of think of it as a more controlled option, which in some ways is attributed to MIGS in general. And there are like a lot of options out there. It gets pretty busy out there in terms of what the options are, and it can get confusing what all they are. We have many different shunts and stents. And this is basically what we've learned from the cardiovascular literature and cardiology literature about stenting in the coronary arteries. Well, we've taken the similar ideas and moved them into the eye. In fact, pretty well all the companies have had cardiovascular engineers working with us to develop these. And we're lucky in many of our areas to have the option to use many procedures. These are my friends from Japan who came to visit for a couple of days, and we did everything under the sun to be able to show and compare. And we're lucky to do that. And I'm hoping to share some of my ideas, because many of you don't have the ability to have all these things, and we're still collecting ideas. We do base procedure selection on target pressures. And certainly for MIGS, in my opinion, although we have variability, of course, in the results, on average, if you look at the studies, we're typically running patients into the mid-teens. So if the pressure target is mid-teens, in that range, I think it's quite appropriate to consider to do MIGS. Any of the MIGS options that we have out there, and there's so many out there we can think about. These are all possibilities you can use. Sorry, the audio is a bit loud on this one. So these are all different options we have available to us. And so we have options we have in terms of cutting, options of dilating, and options of stenting. And these is kind of a way to divide them up. And everyone has their own favorite one. Some of it is based on cost. Some of it is based because we think one device is safer than the other. We do it because we have better access to it. This is a busy slide. Don't have to worry about looking at all this, but what I have on the top part here, I have basically MIGS procedures standalone, and I have combined MIGS procedures, and I have all procedures listed here, okay, and then pooled together. For the most part, they all lower pressure similarly, right? And whether they combine them or not, they can lower pressure and lower medications in general. But usually, again, the pressures are typically in the mid-teens, as I said, and the medications are not all to zero, right? They usually are on one medication or so on average, and that's something to expect. Now, I'm a big fan of evidence-based medicine, and there's a lot of studies that are coming out. Every year we see more and more studies coming out, which is good to see. We also see that the quality of studies may not be the best, but we do have some high quality randomized control trials and some prospective studies that we can look at. We of course need to have more higher quality data. We often hear the complaint that there's not enough evidence on MIGS. To be honest with you, I mean, I think we have never seen more evidence published on a surgical procedure in such a short time period. And these are some of the largest studies that we've seen published in some of these largest randomized trials. These are very comprehensive long-term studies that were expensive to run and randomized. And just to show you, for example, you know, compared to cataract surgery, very rigorous study to wash patients out of medications, wash them out at 1 year, wash them out at 2 years, because medications are a big confounder. And when we do that, we show that there's a significant difference of pressure lowering at, for example, 2 years for these procedures when you combine them with cataract surgery versus cataract surgery alone. To me, there's very little reason not to combine MIGS with cataract surgery when someone has glaucoma. I would argue anyone that point, other than the cost factor, which is an important question to ask, no question, although we do have cheaper MIGS available. And although the data may be not all there, they can be similar in their IOP lowering. And that's the first point. Second point, many of you may say, well, is 2.3 millimeters really useful? Well, part of the problem is when we look at means and averages, we don't get an understanding of the proportional success, number one. Number two, when you go from 18 down to 15, well, you know what? 2-3 millimeters is important, right? That's important when we talk about target pressures. When we go from 15 to 12, when I talk to my internal medicine friends, they go 3 millimeters. You guys argue in glaucoma over 8 millimeters. One procedure is 18, one procedure is 10. You guys argue on this. 8 millimeters is nothing. What's the big deal? Well, to us, every millimeter makes a difference, and it's important. However, there's more to the story because we can get a greater number of patients who are off medications. And medication, we talked about the quality of life, compliance, and everything else. But to me, and this study is being submitted for publication now, when we go to 3 years, in blue, you see the number of patients after 3 years that had to go on to further surgery, trabeculectomy surgery, for example. And then in red, you see the patients who were phaco alone. So you see in blue, phaco plus, in this case, hydrous, protected patients from going on to glaucoma surgery. And we know that bleb surgery is not a small deal. If we can save, 4% of patients from 0.6% of patients going on to needing filtering surgery at 3 years, that's a pretty big deal. Even though 4% is not a big number, that's still a number of patients who we can avoid needing to have filtering surgery. And this number will likely increase over the years. And the reason why is because when patients have mixed procedures, they're on less medications, they're better compliance, and there's better IOP fluctuation as well. And we've also done a lot in terms of cost effectiveness, finally, because this is a very important aspect of thinking about choosing a procedure and how a government funds it. So we have to, again, think about the MIGS mindset. And there are some fantastic surgeons here in the group, in the audience, that do great surgery. I often put this picture up for those of you that have doubts about your ability to do MIGS. This is my friend Alex Topov. I'm like 6'1". This guy is like 7 foot something. And I say, listen, if he can do MIGS, then so can you. So don't be afraid of doing MIGS. And one of the big important things when you do MIGS is those to have the right attitude, to have the right approach when we think about it, and make sure that you're ready for the procedure, that you're ready to do MIGS, and you're ready to make sure that you have the right attitude to approach, okay? So we make sure, for example, all our fellows, they get a massage. Not by me, I'm not gonna get in trouble, but you get a massage to make sure that they're really comfortable, right? So make sure that you guys are comfortable with the procedure. Okay, so this may be some of the basic stuff for learning to do MIGS, but get the right lens. I mean, get the right lens. I can tell you one of the most important things for maximizing MIGS is visibility and visualization. I mean, I've seen, for example, you know, just in front of me here, I see Emilio here, I see Bruno here. Bruno did live surgery recently. It was a fantastic case. But I'm pretty sure Bruno will tell you it wasn't his hands, it wasn't his, whatever his temperature in the room, it was the visibility he had. The view, I'm sure, was fantastic, and he knew exactly where to go, what to do. So, you know, get the best view, work on this, practice this. This is really, really important how to do this, because if we don't get the best view, then it really impacts our ability to properly cannulate the canal or cut the canal or whatever else it may be. That is so important. You know, one thing that some of us have recommended for early surgeons is to inject trypan blue, not for staining the cataract necessarily, which we did in this case, but to stain the trabecular meshwork. I mean, really, if you're not sure and it's a pale, non-pigmented meshwork and you're still learning, go ahead and use trypan blue. You can do dilute formula, but look how beautiful. You can even see the goniotomy I made with the stent opened up, and you can see that. Now, the only complaint I have is, look at my coupling. Look at the coupling here. You see how, you can see how let me see if I can show this here. You can see how the coupling is not complete on the cornea. See this wave here I'm pointing to, right? But my view is still okay. You know what? I want to get the case done. I didn't want to go back and put more agent on this, so I got it done, right? But you want to make sure when you're learning to really make sure you have good coupling on the cornea to be able to see what you do. But there you go. Trypan blue can be used. There's a second stent put in. It really, I mean, it really makes the view better. And of course, there are a lot of other issues that exist as well. For example, if we don't tilt the scope enough, or we don't tilt the head enough, we have what we call a top-down view. We're looking at the iris. Instead, we should turn the head more and get an en face view. So we're like a little miniature person sitting on the iris, looking at trabecular meshwork. And this means we have to tilt the patient's head more. Too often we don't tilt the scope or the head enough, and this can cause a problem. Look at the difference between before tilting and after. Look at the trabecular meshwork. You can see visualized quite nicely here. On the other hand, here you're looking from the top, like you're standing on the cornea, and that makes the view and the challenge there. This is very common for surgeons that are learning, right? We have bubbles in the anterior chamber. You can see that we have blood in the cornea. So be careful with the incisions. If the incisions are too posterior, the blood mixes in the coupling, in the viscoelastic on the cornea, and this is a pain in the butt. The view is not good. Look at the stria on the cornea by pushing down the lens. So be very light, be very gentle with our hands. Hold the gonial lens really, really light, like someone can grab it and steal it from your hand. The view isn't great. We're off-centered, you know, and so be mindful of that to be sure. And you really have to kind of imagine yourself to see the unseen, right? Practice this, go walk around blindfold, whatever it takes to make sure this happens. And really work on ensuring that you have the right view, tilting the microscope enough, tilting the patient's head enough. These are all the basic things. And I'm starting off a bit basic here because I know some of you are still in the learning process, that if we don't do this stuff right, then we don't get the best result. And I also want to mention the hand position. The hand position is very important, where we hold our hands and how we're sitting down as well. We have other alternatives, like, for example, this direct view lens, which I'm shamelessly advertising. I don't make any money on this, and I'm sorry it's a bit expensive, but this is a nice lens. It allows us to get a direct view without tilting the microscope, okay? And so we can basically do the procedure without tilting the microscope with the patient's head, and you can see we get a pretty decent view of the trabecular meshwork. And so this is an option for those that want to get to the procedure and not have to tilt the microscope, although you have to make your hand position a lot lower. And so be very mindful of that. We also debate as surgeons, if we're doing combined cataract surgery, should we do the MIGS procedure first or wait till after the cataract's removed? It is my strongest opinion that doing the procedure before the phaco is optimal. We have the best view, the clearest view, the globe is firm. We reduce the risk of having blood reflux that may occur. Blood reflux is always a pain in the butt. During the cataract surgery, with the fluctuations of the IOP and the softness of the eye, there's more blood reflux. So now when you do your goniotomy or your trabeculotomy or your eye stent, you have more chance of having bleeding into the eye and making it a painful procedure. On the other hand, if I do it before the phaco, I have a much clearer view, a firmer eye, and minimal blood reflux. Now, of course, during the phaco, though, I may get blood reflux in the eye. So that's why it's important to continue to infuse in the eye when we're coming out of the eye during phaco and IA. Keep the eye formed. Inject BSS in the side port so we don't get too much blood reflux. I'm sorry to put up these TM slides, electron microscopy slides, but we need to understand the anatomy. Now, if we're doing GAT, if we're doing trabeculotomies, this is not so important because you know what? You're going to go and you're going to cut through the trabecular meshwork. But if we're putting a stent inside the trabecular, inside the canal, we have to be sure that we fully penetrated through the trabecular meshwork. In fact, you can see the trabecular meshwork is about 100 microns thick, but the canal is actually less dilated or less thick, and especially if the pressure in the eye is high. And so if we're not careful, it's not too difficult to, for example, place the stent within the trabecular meshwork. And this can occur with the first generation stent. With the second generation stent, it's less common, although there is some depth challenges that one has to consider, which I'll speak about. And so consider that. And then I hate to say it, but if we put the stent in the wrong place, you can see the stent is put here, posterior to the trabecular meshwork. It won't work out well. And if it's not put in properly, it won't work out well. And these are reasons why I will argue that I think that those who do GAT probably find they have more consistency for a couple of reasons. One, it's very hard, I shouldn't say this, but it's less hard to screw up a GAT because you're cutting the trabecular meshwork. And you know what? You know you're in there. I hope you know you're in there. And you also don't have to worry so much about the location of the stenting, right? We know that aqueous outflow is not circumferential, it's fairly segmental. Around the entire eye, aqueous only really leaves the eye through a couple of areas at a time. And we know that, you know, in terms of resistance, once we get past 3 to 4 clock hours of resistance, that the overall resistance in the system plateaus. This kind of work here does argue against the need to do 360 degrees GAT, okay? This to me tells us, you know what, if we can do 90 degrees or 180 degrees, as long as it doesn't heal, and as long as we have it in the right area, that we may not need to do 360 degrees GAT. And we're studying this, and I can tell you my anecdotal experience has been that our results with 180 degrees is not too different than 360 for adults. And so it's something just to think about the anatomy and understanding. We also know that in any given outflow apparatus, that the outflow from the canal, let's follow the aqueous, like you're a little miniature little person inside the aqueous in the anterior chamber, and you enter through the trabecular meshwork. Now you're in the canal of Schlemm. From there, where do you go? Well, you don't go around the eye. You basically go right through. The trabecular meshwork canal is basically a pass-through apparatus. It passes through the canal. It doesn't go around the canal when aqueous go through it. If you enter here, for example, basically you're going to enter into a plexus, into a higher resistance system. If we enter here, and you're lucky enough to enter here, you're going to go right into a larger caliber vein, an aqueous vein. And I look at this as an example when, and we can see, for example, light microscopy, you can see the difference in some of the collector channels and the sizes in these, some of these. You want to go for a big size. It's like, for example, if you're in the middle of Manchester City and you have to get out to the highway, would you rather kind of take the surface roads and come here and then go through, or would you rather get right to the superhighway and then leave the city? You want to find these big superhighways, and these big superhighways are described in the 1940s by Asher, calling the veins of Asher, these aqueous veins that come from the canal. And you can see they're filled with aqueous and partly filled with blood. And if we can find where these major veins are, there are only 3 or 4 of these veins present in any given eye. If we can find these veins, this is gold. But of course, to put a stent perfectly there is not so easy. And that's again why if we, do a GAT procedure, we have more likelihood of hitting these canals, these outflow channels, which are very important to continue the aqueous here. We also see that if we were to guess where these aqueous veins are, we know that most of these major aqueous veins are present in the infranasal quadrant. So if we're going to do a procedure in the canal and we're not doing 360 or we're doing 180, we should make sure that we cover the infranasal area preferentially. That's important to do that because that's where we're going to get the majority of action here. And you can see very closely, if you look closely, that is basically an aqueous vein that is leading into the episcleral vein. If you look closely, you can see the laminar, trilaminar appearance of the outflow episcleral vein here. And here it becomes clear, and this is basically the vein. So if we were to put a stent here, this is the best place. If we were to put it here, we may not be in the best location to do that. So that's something to think about as well. There are other ways to look as well and to find the areas where the outflow channels are. I'm at home, so I got my Sophie with me. As opposed to looking outside the eye, we can look inside the eye. And if we look for areas of focal blood reflux or pigmentation, Sophie, I'm doing a talk, baby. I'll play with you in an hour, okay? Then these are likely to be areas where we're going to have a greater point of outflow. It turns out that the most outflow occurs where we have pigment. Pigment gathers there. And so if we look for histopathology, you can see that this is probably near a major aqueous vein. Also, focal blood reflux, you can see on the bottom left, these are likely to be areas where there are collector channels. And so you can see, Sophie, come on, here, play with an egg. And so that's where, if we're gonna do a stent, that's where we wanna make sure that we place the stent in the right location, okay? If we're doing a GAD again, it's less important, right? So let's just go to stenting. This is basically using multiple eye stents, and this is the first generation. Many of you ask, is it better to put 1 or 2 stents in? Well, I think it's always better to put 2 in, but of course, access is potentially a problem, and the cost is an issue, so I totally respect that. And the second generation stent, I think, now allows us to have more than 1 stent. But you can see how we're lining up the sharp tip of the trabecular stent in the areas of trabecular meshwork, and then we're going to enter at a steep angle. Believe me, I have to operate in the OR with everything happening, so I'm used to this, no problem. And then we'll basically make sure we turn our hand to follow the curved nature of the canal. Remember, the stent is straight and the canal is curved. And so if we just enter straight, we're going to basically hit the outer wall. We want to make sure we turn our hand. It's very important. And this is being done before phaco, so we don't have a lot of blood reflux. Sophie, you have to let me finish this time. Okay, sit down over here. Sit down on the chair then, because I don't want to watch me. And so get a chair. Go ahead. And so you see blood reflux is normal to see that. Whether blood reflux is a good sign or bad sign, to me, is probably not fully understood. I think it's a good sign. It means that there's patency in the system. Does it mean that the procedure is going to work for sure? Not always. Not always is that's the case. And so you can see we're putting a couple stents in here. And then what I sometimes do afterwards, and this is a nice proof of system here, when I inject trypan blue, you'll see it's taken up by the veins, and it's only taken up into a small area, and that's basically where the canal stent has been placed. And that's important to consider to know we have this. And like I said before, some of the in vitro work has shown that putting more than 1 stent does reduce the resistance more than a single stent. So we typically do more than 1. You can see in this case, we have stained the trabecular meshwork with trypan blue, placing the stent in the area of the canal. Look closely though, you don't need vision blue. Look at the blanching. Look at all the white blanching because of the aqueous outflow. Now, when I lower the pressure in the eye, look at the episcleral vein fill with blood. You see that? I'll do it again. It fills with blood, and then now I'm going to pressurize the eye and look at the vein fill with BSS. It's very cool to see that. And it's because, you know what? I hit the oil well. The stent is put exactly in front of where that vein is in the trabecular meshwork. So that's what we want to do. Here's a before. This is before implantation, and here's after. And you can see the vein becomes diluted because of the BSS. So it's pretty cool. Now, the Glaukos, of course, has now moved forward with a new generation stent, which is designed to be essentially easier to put in and perhaps might be more predictable because of the difficulties potentially with the first generation stent. It comes on an injector, and you can see that this is simply like a thumbtack, like a rivet design. Sophie, come on, seriously. There's the two devices in basically lined up in the guide wire, right? The guide wire is inside the lumen of these devices. They're back to back. It's like a Pez dispenser. And you can see, if you look right in the barrel, the stents are present there. And you can watch what I'm doing now. I'm looking for an area of pigmentation. I'm looking to see where the pigmentation and blood reflexes, and I want to put the stent right there. And why? Because I believe that's an area where there's likely to be a larger episcleral vein. So location's important, thought's important as well, and it's important to consider that. The other thing that we don't often talk about, again, is the hand position. So in this video, I'm just going to show you my hand positions and the body positions here. And you see how the scope is tilted. You can see how I'm sitting back. My hand is pretty flat. Now, when I'm doing a stent and I'm right-handed here, and I'm putting the stent on the left hemisphere of the eye, I hold it like a pencil because this gives me a good approach, if you can watch the video here, of my hand. So now I can go in, look at my hand, I can go and press the button, and I have good control. Okay, and there you see it. Now you're gonna watch closely. When I'm gonna go to the right side, I'm gonna change my hand grip from a pencil to more of a cigar like this, okay? And by holding it like this, my right hand, I can basically place the stent in this case, supranasal quadrant. Too often I find people doing this surgery and they're putting the stents too close together. And I think it's beneficial for us to see how I just changed my grip. And look, I'm even turning the microscope. So take the time. I see people do stents and they go 1, 2 so quickly. Take the time to go slow, plan it out, and place them farther apart. Why put them 1 clock hour apart when you can go 3 clock hours apart? But you have to turn the scope, you have to reposition your hand grip, and you have to be able to then, again, visualize the area. So you can see again how we're putting it in there. The one challenge we have with this procedure, and I can tell you it's a significant challenge, is that if we push too hard, then we put the implant too deep. And this is a common problem that can happen. And if we don't push hard enough, then the canal will bounce, then the device will bounce off the trabecular meshwork. So we talk about dimpling in a little bit, and this is the right amount of pressure, but that's a very subjective concept, and it may depend on the pressure in the eye. So the new G2W, which is brand new, has answered some of these problems. And you can see it's got a wider flange. The head and the thorax are similar, but the flange is wider. And so you can see the difference between the first generation stent on the left, the first generation G2 versus the G2W. Emilio, is G2W available in Brazil? Not yet, okay. So this is the difference in size. You can look at the difference there. And this is what I did. I did live surgery in Spain recently. We're all wearing glasses because we're doing 3D. We're using 3D, the Artivo system. And just to show you here, and this is nice because look, I can sit back and do the surgery. It's kind of nice. Again, you can see I'm sitting back in my office too with my little troublemaker here. You're gonna be in trouble later, you know that. Yeah, you know that. You're gonna have to be punished later today. You're gonna be big trouble here. I'm not a good punisher most of the time. And you can see that the sensor lined up. Now, the only difference is here that with the pressure you put in the eye onto the trabecular meshwork, you need to put some pressure, but you don't have to push so hard. It's just very gentle, for me at least, simply putting it appositionally so you're just touching the trabecular meshwork. And then you deploy the implant, and you can see the blood reflux, which is normal, but the flange prevents it from getting buried. Trust me, for those of you that have not done the procedure, that's the biggest challenge. The G2 seems easier than G1, but it's harder because you have to push the right amount of pressure. And if you push too hard, it's too deep. Too superficial is too superficial. And I have lots of videos to show the problems with that. And here you can see the positioning here, and we will then have the implant placed in there. Okay, we're good now, at least for another few minutes. Okay, come back in half an hour, Sophie. Now, one alternative option for stenting is the Hydrus device. And the Hydrus device was trying to address a larger area of the canal, number one, and also trying to dilate the canal. And so this device you can see being placed, and I presented a couple of surgical studies results earlier, where the cannula is used to incise, and the device is placed in there. We cover 3 clock hours, and so therefore, theoretically, we have access to a larger area of the canal, which can be of our benefit. And then moving beyond the canal stenting, we have, of course, dual blade, which I think is something that's available in Brazil. 2 blades that are used to cut the trabecular meshwork anteriorly and posteriorly to get a strip of the trabecular meshwork. This is, again, a procedure that I would say is technically not as demanding as stenting, but to do it perfectly, it's not so easy. In other words, you have to have the KDB blade really on FOSS with the trabecular meshwork. If there's a tilt of the blade, then we only cut one part of the canal. And we typically then only cut the anterior ridge, and the posterior ridge will stay attached. So we have to make sure that we really, really approach the trabecular meshwork en face. And that's an important pearl with the KDB, because the advantage of KDB is we're actually removing a strip of the canal, which may be beneficial in terms of preventing it from closing. Maybe, we don't know for certain. And you can see how we're basically making a cut on one side and then coming across. It's usually difficult to get more than 90 degrees of the trabecular meshwork with this as well. And then we'll move on to using catheterization and suturing to intubate the canal. And here we're using the iTrack, which is a beautiful catheter, which can be used to inject viscoelastic. Again, it's basically a more, multiple mechanisms of action here that may work here. And you can see we're basically made a goniotomy. And one of the tips is, of course, to have the good instrumentation. And you can see the micro forcep is used to advance the catheter forward. In this case, you can see in a counterclockwise fashion. And sometimes it's difficult to get the catheter to go all the way around. And usually it's because, not because the canal is discontinuous, but because there's probably a bifurcation of a collector channel that is hitting against. This can be done 180 degrees, this can be 360, this can be with injection of viscoelastic as well, which we think may or may not be helpful as far as flushing out the system. Because when we do GAT, or when we do tracheotomies, or iStent even, we're not necessarily addressing any resistance beyond the canal. And there might be problems with collector systems that there may be adhesions present, as some of the studies have shown, that we don't get through. This is a 360 degree, and you can see the nice opening there that's present. And then, of course, we have the GAT procedure. It's popularized by Devinder Grover and Feldman's group. And then we have modifications. And this is a video from Patrick Gouy, who has done a lot of nice work with the GAT procedure and the ab internal trabeculotomies. Our Japanese friends also, I should mention, were some of the original surgeons who described this as well, and deserve a lot of credit as well with this technique, ab internal approach. And this is, again, a procedure which I would say universally around the world is a procedure that can be done around the world because we don't need to have a stent or special, expensive procedures. Now, we can debate which is better, which is safer, which is more predictable. That's something you can debate. But certainly, I think for everyone on the call here, this procedure is something that can be done well. You can see the 25 gauge needle is used to make a cut. Viscoelastic in the needle can be helpful to inject if you get blood reflux. And then we're basically going to advance the suture. It's either 40 quick pushes or 20 longer pushes to get 360. Usually, once you get resistance, you know that you're at least 180. And you can stop there if you want. I'll explain that in a second. This is 360 here. And again, having a little cautery to make that little round nose tip help. This is using 5-O-proline. We were talking to Zainab from Turkey, who's a wonderful surgeon in person, who described using 6-O as well. And you can see them basically, we're essentially doing the same thing we showed earlier with the catheter. But I can tell you that I very rarely, when I do GAT, do 360. And I think work that Patrick has helped with and Matt Schlenker and others, I think really are pointing to the fact that 180-degree goniotomy is likely going to be enough, but hyphema is probably reduced. And that may be a benefit, of course, because sometimes hyphemas can be a real annoyance for our patients. So we're passing it forward and then basically, pulling the suture, making sure that we stay close to the angle to do so-called walk the dog and re-grab if you need to. And, even though the first thing you think about is you're going to pull the suture out of the canal, it's pretty rare for that to happen, actually. It pulls out quite nicely, and the round nose tip stays at the temporal side, as you see there, quite nicely. Now, as an all-in-one package, there's the Omni system. I know Jeff Maltzman, my colleague and friend from Tucson, Arizona, I see here. And Jeff's a fantastic guy, man. Always warm to see you here, buddy. This is basically essentially similar to the GAT, but we have a suture element which has a lumen inside. You can see the lumen inside there. And so this allows us to inject viscoelastic as well. And it doesn't require suture to be outside the eye. It's all built into one. It can also be done, for example, with the DVX lens. It doesn't have to be tilting the scope, as you see here in this example. And so, it's kind of a nice, convenient way to do this. And so I would say that when we have to do GAT or we have to do visco dilation, this is a very handy approach. all of these procedures really, this is a phakic patient. All of these procedures really are achieving the same thing. We're basically, and I hate to use the word, we literally are ripping the trabecular meshwork. We're ripping open the trabecular meshwork. We're tearing it open, which is fine. I don't like the idea of ripping necessarily, but you know what? It does work, and it's straightforward to do. Look at the DVX lens. You can see 360 degrees. This is a nice feature of using this particular lens, double mirror. Remember, I don't make any money on this lens, and I know it's expensive. I know I owe somebody on this call this lens. You know who you are. I'll have to get it to you somehow. I can blame COVID. That's why I can't send it to you. You can see how I've not tilted the microscope or the head. We're now entering the curvature of this cannula. It's a little bit tricky. You see, we cannot enter quite flush. So we're entering a bit steep, but the goal is to basically make a goniotomy, make a scratch, and then the roller wheel will advance it. And it's kind of a nice technique. And the lens, you can look at that, pretty cool. You can see with the lens, the catheter moving around, which you can do with GAD as well. It's kind of fun. I have to send this lens to you, Bruno, if you don't have it already, because I think you would enjoy this, my friend. That's, oh, damn, another person. Now I have two people I send the lens to. Now you can see it. Now when we retract the catheter, the viscoelastic is being injected automatically. Viscoelastic being injected, because I've already injected viscoelastic inside the lumen of the catheter. This patient has some blood reflux. You have to be prepared for it. Use enough viscoelastic. That's what I would say. And flush it out if you need to do that. Now I'm going to do the next 180 degrees. You see, I didn't really do goniotomy on that side. I just basically did viscodilation and a little small goniotomy in the area where it's infranasal. But here, what I'm going to do is I'm going to go forward, and you can see the suture go in. As we retract, we're injecting viscoelastic, so we maybe are flushing the collector system, which might be nice. It's an additional feature beyond GAT. And now we're going to pull again to do that goniotomy. And I'm doing it while you can see it too, which is kind of nice to show that. You don't have to see it while we're doing it. And there you go. So now we have the goniotomy, trabeculotomy done 180 degrees, as you see here, and viscodilation for about 180 degrees. Now, it's important to leave the eye firm at the end of the case. I inject about 1/3 of viscoelastic in the AC, but sometimes it's hard to know how much you're putting in. Keep the eye pressurized at all times. Otherwise, you're going to get blood reflux. What I do is I put air in the AC, and then I follow it up with viscoelastic. So now I can see exactly how much OVD is in the anterior chamber. If you inject OVD without, it's just BSS, you don't necessarily know how much OVD is put in the eye. But now you can see I got it firm, and this really prevents it from happening. The last procedure I'll talk about on this is someone asked me on the chat group, and thank you, Alberto. This lens comes from Ocular Instruments. What is this? These are excimer laser openings, ELT, which has been around for a long time, and we're kind of revisiting it a bit. Again, this is shameless advertising. This is not the manufacturer of the Ahmed valve, right? And you can see using this lens and using this fiber, it's very cool. We make these small little openings, trabeculostomies we call them, by pressing the foot pedal. This is probably less learning curve to learn to do. And you can see I'm going all the way around. I can do it everywhere. I can do it infratemporally as well. And this actually was with Antonio Moreno. I did surgery with him in Spain, Albacete. And we can see we can go all the way around. So there's a lot of options out there that are present. And I would say that each of these approaches have their pros and cons and something to think about. I will talk just very briefly about post-op, because post-op management is important as well. Just make sure that we keep in mind that steroid response can happen, so don't use too much steroid. Lotemax is fine, loteprednol if you have access to it. I typically stop the pressure medications right away so we don't get hypotony or blood reflux in the eye, but we may have to restart it again if they get a steroid response. So that's important to know that. Toward the latter half, I'm going to talk about bleb, because we still have to ask a question as Shakespeare did. The question we have to ask ourselves is to bleb or not to bleb. In fact, when I have a patient who comes to see me in the office, literally the first thing I ask myself is, does this patient need a bleb? Because as a glaucoma specialist, ultimately I'm trained to lower pressure with surgery and lower it well. And there's nothing better than a bleb. We can't get away from a bleb. So we have to ask ourselves, do we have to go back to the bleb? Because we've been talking about MIGS a lot. Do we go back to the bleb? Because I can tell you, once you go back to the bleb, you may never go back to the bleb or from the bleb. This is my friend, and this is my former fellow, Arsham Shabani, because the bleb certainly is the best way to get the pressures low, and we can't beat that. Now, this video is freshly edited. I edited it last night, actually, because I didn't have a recent trabeculectomy video, because I don't do many trabeculectomies. This is one of our fellows. This is actually Valentina's video. I actually edited your video, Valentina. I don't know if you're watching or not. Maybe you're, we'll have to share with you later. Tiziana can tell you about that. But you see, we're opening up Valentina's opening up the conjunctiva at the limbus. And what I want to point out is one thing right now, is be mindful of tenons, because tenons is really, really important, and it can be a friend or an enemy. And when we disinsert tenon, remember tenons inserts at the 1.5 or so millimeters from the limbus. You saw that the suture, the scissors were used to disinsert it. This tenons typically retracts to the back. It retracts into the fornix. You have to go and get it. Don't leave it, in my opinion, because if you leave it and close without tenons, then we get a more avascular bleb and a small bleb, and tenons will scar down where you leave it. Where tenons is cut, it'll stop and it'll scar down, typically 5 or 6 millimeters from the limbus. And that prevents us from having a posterior bleb in some cases. Look how you saw how we grab tenons nicely, hold it there, and then dissect more posteriorly. Don't just put the scissors blindly and shove them back there and just dissect. Because you know what you're doing? You know what you're doing when you do that? You're basically traumatizing tenons. You're leaving tenons on the sclera. And I'm going to be pretty harsh, because I can tell you probably 70% of glaucoma surgeons do that. And I don't like that. I'm going to be honest with you. I may be wrong though, but I don't like that. We should be working under tenons, not just blindly putting scissors back there and doing it. Now we can go and spread and nicely open up the space. And then either put sponges, and look, you see tenons is attached to the conjunctiva, but it can be separated too. This is important to mobilize it. And you'll see why it's important when it comes to Zen and when it comes to pressure flow, some of the new bleb procedures, because those procedures to think about. This is mitomycin C I'm injecting. I'm injecting mitomycin C. Well, Valentina's injecting mitomycin C here. And rather than using sponges, injection is just a more reliable delivery mechanism. And you know what? It's nicely filling the posterior area there. We're dabbing it away. And no, it's not going to cause toxicity. You're not going to get a melted bleb. No more than you will for a sponge, in my opinion. On the other hand, you make it a more diffuse bleb. So I inject. You can do it transconj with a needle, but since we're already opening the conjunctiva, why not do that? And then we're going to basically make a flap. I like to make a rectangular flap. You can see I'm just helping my fellow, telling exactly where to make the cuts and the incisions. Typically, the flap is about 3.5 millimeters wide by 2 millimeters long, and we don't want to cut all the way to the limbus. We make basically about a 3/4 depth cut through the sclera, so we go all the way deep, because we do not want the flap to be too shallow. And then we'll tunnel forward before cutting the radials. I found that by doing this, it's easier to maintain the plane. However, if we don't change the direction of the blade, then we can enter the anterior chamber. So once we get close to the limbus, or the blue zone, I should say here, we need to tilt the blade up. Otherwise, we enter the anterior chamber. And this just provides a nice plane. You can, of course, cut the radial flaps and then lift the flap up and do it if you want. Of course, many people do that. I did that before too. But this is just, I think, a nice way to create a nice blade. Now watch how the section is going to be carried into the cornea. We want to make sure that we enter the anterior chamber quite anteriorly. And however, we don't want the radial incisions to be all the way into the cornea. There's no benefit for that. We want the radial incisions to be posterior. So watch, you can see how the radial incisions are hung back, like a millimeter back, because we don't need to be all the way into the cornea. We want to basically have the flow to go posteriorly. Nice smooth dissection, good job there. And then before we enter the eye, we pre-place sutures, 10 nylon, and then enter the eye. A paracentesis has already been made over here. And then we can make a punch, typically one punch is needed. And now you can see how we will then make a nice opening there. Now, again, it's been a long time since I actually narrated trabeculectomy, but I wanted to just show my approach, or my feeling of my approach. And you can see the trabecular meshwork in there as well in the specimen, nicely shown there. Iridectomy is optional. We don't always do it, but if the iris is presenting itself, then we do it. But if the chamber is nice and deep, we don't have to always do it. And then the flaps are sutured down with slip knots. We inject BSS to the side port, sorry. I do not like to lock the nut right away. A slip knot is nice to be able to tighten the tension. So we inject BSS. You know what? Too much flow on the left there. Too much flow there. So you know what? We can tighten the suture down and get it a bit better. So that really helps us to get the tension right. And then once we're happy with it, we lock the sutures. And then this is the last thing I want to mention. Bury your knots. This is using 9-0 Vicryl, but don't just close the conj. Watch closely this point here. Suture needle through the conjunctiva and then grab tenons and bring it forward. The advancement of tenons back to this position, I think, is really important. And for me, it's really maximized the trabeculectomy results by creating a more diffuse bleb that flows under tenons first. It also prevents a very localized thin bleb anteriorly. And it allows me to use more mitomycin C and to inject mitomycin C because I have the comfort of having tenons. Tenons is like a sponge. And it really absorbs nicely. Of course, trabeculectomy, there's so much variability with trabeculectomy. And this is the reason why many of us have said, should we go to something else like microstenting? And the two approaches we have available to us are the Zen, which can be ab external or ab internal typically in my hands, or the PreserFlow, which is an ab external approach. These both create blebs, and you may say, why do this if you can do a trap? Well, this is much more controlled in our hands. The recovery is better. I believe it's safer, and the blebs have better morphology. But remember, the physics are always important, and the physics of outflow from a flap versus a single stent are different. And the tissue reaction around the actual outflow will be different, whether it's coming from one focal point or from a diffuse area in the early postoperative period. So don't forget that. Tenons is important, and we have to remember that tenons varies between individuals. It can be traumatized and cause problems, and it can be a physical barrier as well. And when we, for example, use the Zen implant, it's nice to be able to get the needle through tenons and try to get it as superficial as we can. This dissection just shows you, for example, bigger dissection shows you what I've done here. I've separated conjunctiva and tenons. Most of us don't see this view here, but this is why it's important that when we open and close trabeculectomies, we have to manage tenons. And when we do microstenting, we have to also respect tenons. And you can see the tenons present here underneath the conjunctiva and above the sclera. But usually tenons is attached to the conjunctiva and attached to the sclera. But you can see we're making a nice super tenon space present here, which can be used for different reasons. The Zen is a nice flexible gel stent. It's very biocompatible and sits nicely under the conjunctiva, and the blebs, for the most part, not always, for the most part, are nice and diffuse. But I think the placement of the Zen is important. And this is where I believe placing the Zen anywhere but not in tenons is important. Putting a subtenons is not easy because tenons is usually attached. And so making efforts to make sure we get as superficial as possible is important. And recently, you know, Vanessa Vera, one of my former fellows, who's from Venezuela, I should mention, shout out to Venezuela, who now is in the US, really smart and warm, great person. We talked a lot about these procedures and about optimizing the approach. This is my most recent approach with Zen. I do believe a traction suture is very helpful for these procedures for exposure. So again, I'm talking about maximizing my results. Well, you know what, exposure is important. Use a traction suture to control the eye, both during the delivery, but also with the mitomycin. Notice that the incision I made here, this is a side port incision, but notice with my main incision, I'm making it temporal. I'm not making it inferiorly because I want to enter and I'm making it directional. Incisions are directional. Point the incision to the direction you're going to work in. And I'm making it temporal because the Zen is going to be placed here again, more at an angle here. And here we're going to enter at just above the level of trabecular meshwork, place the needle through. And this is the most important part. Make sure the needle is visualized very clearly. You can see the reflection off the needle here, telling us that we're not stuck in tenons. And that's important to make sure that we reduce the resistance around the implant. And then we'll deliver the implant here into the subcon space. And you can see the implant in the anterior chamber, which is what we want to see. I believe these implants are very well tolerated by the cornea because you can see how away from cornea is and how small it is and well positioned it is. And then I like to make sure I play around with the implant, make sure that the implant is very free and mobile. because this will tell us that it's not stuck in tissue. And then at the end of the case, what I do now, not before, but now, I inject my mitomycin C after. Why? Because I can use the needle while I'm there to just sweep around the implant to make sure that there's nothing around the implant that might be a problem, like tenons. So I just swipe underneath it. Be careful not to hit a vessel. It's really important. Do it under good magnification. And again, use the traction suture and tack it down to pull the eye down. And you can see how nicely we get the area freed up. And then after we do this, we can inject mitomycin C just behind it. No, I don't have a problem with mitomycin injection near the implant. The mitomycin is going to go in the area of least resistance. It's not going to enter the eye. Trust me if you believe me. But this has not been a problem for us. And then we basically will remove the viscoelastic at the end gently, and we get a nice bleb that forms. This has been an ideal approach for us. So make sure we address some of these important factors. I'm not going to go through all the results, but basically know that there's now different approaches that are used. There's ab internal, like I just showed you. There's also transconjunctival. And transconjunctival has kind of been a bit of interest here, particularly in the US. And I think some surgeons feel comfortable with the ability to put the implant in and try to be more sure they're above tenons. But make sure you know the landmarks. We want to enter the eye about 2.5 millimeters from the limbus, 2 to 2.5. Want the implant to be sitting farther back, at least again 2 millimeters back from the entry point, at least. Enter the eye 7 millimeters, enter the conjunctiva 7 millimeters back. We advance the needle forward. We turn our hand to basically enter the eye. This is sitting temporal, with supratemporal here. Engage the sclera at that point. Again, it's hard to see, the conjunctiva is pushed together, bunched together. Enter here, following the sclera, and then turn down to enter iris plane once we get to near the limbus. And now we make our slider go forward. Remember, this is off-label, and the injector is not designed for this, so it can be tricky. But don't, watch my hand here, don't push the slider all the way forward until we've actually pulled back the cannula, which is very different than ab internal. So we want to go 3/4 of the way forward and then stop, and then pull back with the cannula. And that's the approximate level, and you can see we have the implant well positioned. And so ab external is another alternative as well. Finally, just to mention about pressure flow. Pressure flow implant is another alternative, and we've seen the procedure being done in some parts of the world. This is basically a similar opening to what we do for tube shunts. It's a fairly big opening. Again, you're going to see very carefully, we're going to identify tenons, because we have to make sure, in my opinion, that tenons is not retracted and left behind. Otherwise, the shunt will be basically sitting right where tenons will be stuck down on the sclera, which is back there. Make a nice big pocket. We can use mitomycin C with sponges or injection. We enter the eye with a 1 millimeter blade, and then place the shunt, or the micro shunt, into this space with a little fin that hold it in place. And there's the flow. And then we're going to close. Watch, we're going to carefully close tenons. We're going to tuck the implant underneath tenons. So now it'll basically be present underneath. It's different than Zen if we do it ab internal. And we can then make sure it's not stuck. Look how the implant wants to get stuck in tenons. So be very careful. That's why a nice dissection is nice to see that. My tip here again is make a good dissection so you can see nicely. Even when we do that, look at the implant stuck in tenons. So be careful and go back and look and free it up. Believe me, tenons can be a friend or it can be an enemy. And here it can be an enemy because if that single outflow source is stuck in tenons, then that means you're going to have high resistance for Zen or for this procedure. And we close it together there. And the blebs you can see are pretty nice in that manner. So that's a lot of information there that I've explained to you, Alberto and gang. A lot of options present. I've written down lots of algorithms, which we can talk about later if we wish. But that's a lot to handle here. I'm sorry I kind of spoke a lot here, but I guess I covered a lot of things. I want to make sure the group heard me. So I'll stop here and hopefully have a chance to talk a bit more. Thank you for listening again.
Amazing presentation.
Yeah.
As you said, you covered all the MIGS procedures and also the blebs. So let's open discussion, but I have one more. I have a first question here. So about our talk from the airport to the hotel here, we covered some issues like from a developing country perspective, like Brazil. So cost here is a big issue for us. So we talking about the GAT. Okay, the GAT is a low cost procedure. And also the you mentioned about the pressure flow, but I don't think this will be actually expensive as well.
Yeah, so most of these devices are going to be in the same range, you know, US dollars, like around $1,000 US. So you're right. This cost is certainly a factor, no question.
So the cost of the pressure flow is almost the same as the Zen.
It's probably going to be that way. Probably going to be that way. Yes.
Okay. And you mentioned about the tandem management. So
one thing I want to mention, Alberto, though, one of the problems we get into, we talk about cost, and we talk about the cost of the surgery. But I think really, to be fair, we should be thinking about the cost to the patient's lifetime, or at least the post-operative period. So for example, you know, there's a cost to do suture lysis, there's a cost for the laser, there's a cost for visits, there's a cost for complications, there's a cost for drops. You have to take, you know, 5% of your patients back to the OR. There's a cost for that. So, I mean, although we need to really map it out, we have to be careful thinking too short term, you know, and I think that's hard to understand, of course. But I think that's an important concept, because cost is really a big picture. Second point is that really, and any health economics will tell you that question, we don't typically choose a procedure based on cost alone. That's budget. We choose on quality of life and cost. So for example, we look at cost utility, we look at cost effectiveness, we look at quality adjusted life years. These are complicated things. We use Markov modeling to model, you know, the quality of life and the costs. So it is complicated. We have published on this in our journals on looking at these surgical procedures. We need more to do. But at least immediately, the reality is that if your hospital is not going to buy the device, or patient cannot afford it right now, you don't have it available. So that I wanted to make that circular point. Sorry.
So do you think a fair comparison will be like you're doing like a 5-year comparison, like for example drops, laser, and
yeah, I mean, so of course, the longer term study, the better, of course, but we have to use some modeling to extrapolate in the future. I mean, that's kind of what we have to do, because to follow every single patient for 5 years is a challenge, right? We like to do that, but our societies, we need to have better data, and I think you're right. Longer term data as well has to be considered to this as well. The other thing we don't think about, for example, trabeculectomy versus Zen or pressure flow. You know, there's difference in refractive error, astigmatism generation, comfort. All these things are also important to the patient, but doesn't get captured in the results either. And so these are all variables which make it difficult to kind of prove. If money wasn't an object, it would be different, of course. But I completely understand. I understand the challenge with that. I just want to mention that we need to think about all of these aspects when it comes to choosing a procedure.
So great, Marcos. You can start with the chat questions.
Okay. There's a lot of questions, Marcos. I mean, I'm happy if you want to read them. I can answer them too, but let me know, because there's some good questions that came up.
Yes, I took notes here. And so the first one was on the first part of the presentation. It's about doing the MIGS before you make the phaco. And who is asking? Let me.
They're asking about viscoelastic or cortex getting stuck in it, right?
Yes, Enrique Leber was asking just that. If the cortex or the visco can occlude the MIGS, if you do it first.
I don't believe so. I think that the you know, the turbulence in the circulation in the anterior chamber, it's going to be very unlikely we're going to get something to go through that very small, very small collector channels and openings. So I don't think that's a problem. I mean, we looked at our results before and after. We don't find a difference in the results, to be honest with you, as far as those things. Viscoelastic may not be a bad thing, by the way. I mean, sometimes we inject viscoelastic as well, like I said. So I really don't feel it's a problem for lens material entering the stent or entering the trabeculotomy or GAT area. I think it's not going to be a problem to actually go in through the system and go into the veins. I mean, that's something that would be, I think, physically impossible. That's my opinion, of course. And
okay, I agree with you.
Oh, thank you.
Another question from Claudia, Brazil. She's asking about GAT in genital glaucoma. What opinion?
I think that, you know, goniotomy and trabeculotomies were first, well, they were described in adults as well, but it didn't really take off. It's funny because people were doing trabeculotomies in adults for a long time, ab externo, right? The Japanese were doing them, you know, internationally they were being done, but they fell out of favor because it was felt they weren't sufficiently lowering enough for patients, because the amount of lowering was perhaps, so the expectations were different. In kids, of course, they've been around for a long time, and these patients often have a dysgenetic apparatus, trabeculomesenteric apparatus, the Barkan's membrane type of situation there. And so they can be very effective. And so absolutely, this is our first choice for pediatric, for congenital glaucoma. And I think to do it ab interno would be preferable. I do think that using the eye-track catheter, which has the little red light, makes it easier to cannulate and to follow, because using a suture is just a little bit more challenging to be able to follow that in some of these unusual canal systems in these pediatric eyes. But yeah, this is certainly should be the first approach. I think the patients who are in that category, uveitic patients who have open angles, those patients do quite well with trabeculotomy, ab interno trabeculotomy, GATs, things like that.
Ike, how do you manage like pilocarpine after GAT?
I don't use it routinely. I will say that if I do feel that the iris is close to the openings, sometimes we do see PAS formation, particularly in patients who have angle closure or have maybe a high iris insertion. And so in those patients, I may use it right off the bat, but I generally don't for most patients. Post-operatively though, if I'm worried about synechial formation, we'll do it. But I'm not a big fan of pilocarpine. I mean, I don't know how often patients use it anyways, but when they do, it's, not comfortable, and it certainly can be pro-inflammatory. So it's usually a short-term thing. So it's not routine for me.
Okay, another question is Maritza Quintero. Dr. Ike, Maritza Quintero, what do you think about position of the bed? She's asking about
yes.
Elevated bed position.
I saw her question. Yes. So just a word about Maritza. So Maritza is from Venezuela originally, and I think I met her at a meeting, right? Maritza, I don't know where, academy, and she was really energetic and came up and said, I want to visit you. And I said, okay, send an email, right? So she sent an email a few years ago, and I think I ignored her for like 3 years. And then somehow she came to Canada for another meeting, and she bumped into me at a meeting I was chairing in Ottawa. And she's like, I'm going to come over and see you. And then she came to visit with us, which was great. She's a lot of energy and positiveness and very smart. So thank you for visiting with me. So a very important point. I didn't mention it. Thank you for mentioning it. That blood reflux is a common problem when we do these mixed procedures in the canal. And anything we can do to reduce the venous tone is going to be beneficial. So as you said, and as you know, Maritza, we do in the OR, we're putting the patient in reverse Trendelenburg. The head is up, and that reduces the blood reflux to the patient. And I think that can be helpful, again, to get the best view. And so absolutely great idea. I think I recommend it for all these cases. I recommend it for phaco even. I always want my patients to be reverse Trendelenburg by some degrees, and the patients are more comfortable. So there's all good reasons to do it. You should do it for every case you do for eye surgery.
Excellent. Other questions here is about Zen. When do you recommend, do you prefer use the Zen implant? Which patient?
Yeah, so I mean, I will say that we do a fair amount of bleb surgery. So when I want to do a bleb, I'm thinking about this. If I need a patient whose pressure has to be down into the low teens to 12, I'm thinking about one of 4 things: a trab, a tube, a Zen, or a PreserFlow. I used to say non-penetrating surgery, deep spherectomy, but now that's become really minimal now because I have Zen and PreserFlow. If I need a pressure down to like a level of 8, then I'm going to go to trabeculectomy. If I need a pressure that I think is going to be okay for 12 to 14, 12, 13, then I go Zen or PreserFlow, which for me is most of my patients. Most of the patients don't need a pressure of 8 in my experience. Between Zen and PreserFlow, we don't have the answer. Of course, Zen is, I do ab interno. It's a pretty slick procedure. I'm in and out. However, there is more needling around Zen than we get with PreserFlow, partly because with PreserFlow, we're opening the conjunctiva and we know exactly where we're placing it. But there's more work during the OR. So someone who's younger, who's more likely to scar, a patient of a black patient, for example, I'm more likely to shift toward PreserFlow. An older patient, on the other hand, Caucasian, less likely to scar. I think a Zen is quite reasonable to do that, or combined with phaco. So for me, I think it's still kind of up in the air as far as that. But yeah, I mean, between those two is what I basically call subconjunctival MIGS, and that's, you know, the majority of surgeries that we do for glaucoma, because our patients need to have those lower pressures, and we want something that's going to be safe and consistent and rapid recovery. And in my hands, I can be honestly tell you the results, and we published our results with a multi-center retrospective study. The results are very similar to trabeculectomy in my hands, my experience, and others as well. But I will say technique is important. I mean, I hate to make that an excuse, but it's like the early days of phaco, right? When people were saying phaco sucks. Well, part of it was the machine, part of it was understanding, but part of it was the surgery. And it was difficult because, you know, extra cap was a good procedure. It was working out great. My results are fine. But it only came forward when phaco became so safe, and when patients expected results to be faster and quicker. And when, you know, the technology got to the point where surgeons were really good at it. So that's kind of where we're at with some of these mixed procedures and Zen and pressure flow.
Emilio, you want to make some questions? Do it, and then we came back with the chat here.
Okay. I have three questions. The first one is following the track of technique. And what is your settings of a microscope? Do you keep the same setting as phaco, or do you change the illumination regardless of the zoom? But actually, I'd like to know about the illumination. Okay.
Yeah.
The second question. Okay.
Okay.
Can I make the three questions?
Yes. Go ahead. Go ahead.
And the second one, if you have any kind of experience with Ologen for surgery. And the third one, due to MIGS safety, why these procedures cannot be useful for advanced glaucoma?
Oh, great questions, Emilio. Great questions. Okay, so I can talk a lot about the microscope. First of all, I think the most common mistakes people make with microscopes, and not only juniors, but also senior surgeons, is number one, they're off the screen or at the end of the, not centered. Number two, they're not focused, which can be from accommodation more commonly in younger patients. Number three, they're too zoomed out. They're too zoomed out, which can help depth of focus, but doesn't give us the kind of detail that specifically for angle procedures you need. So even in phaco, I probably tend to zoom in more than others, but then I have to focus more too. And I think that's a bit difficult for surgeons when you're learning because you're worried about phaco. You don't want to be focusing too much. But I like to zoom in a lot. That's important. And then the fifth thing is people use too much light. You know, during phaco, man, the thing's cranked up there, and the patient's getting like retinal toxicity as we talk, and you're getting retinal toxicity, and it's bright, and you lose your it's over contrast. So I tend to actually turn my illumination down in general. However, when you're zooming in, as you know, when you're zooming in, to account for the loss of light, you have to go put the illumination up, because you know, you all know when you zoom in, things get darker. So if you do that, you have to basically turn the light up to get enough illumination. So I would just in general say that if you're zooming in, you got to use more light, but overall, don't use too much light than you need. Just use enough. And most of you don't do this, but I have the light control on my foot pedal. How many of you are using the light control on your foot pedal and actually using it while you're doing surgery? Most are using the X, Y, and the focusing and the zoom, but most are not changing the light during the surgery. I'm changing the light during the surgery. And not only that, you have two light sources, for example, on many microscopes. You have the red reflex, coaxial, and the peripheral light. So you can change the red reflex and the coaxial light as well. So, you know, as a surgeon, you have to be multitasking. You have to be like a helicopter pilot. You have everything moving around you and monitoring it, right? So that's important. Okay, so Ologen's great. I've been really impressed with Ologen, to be honest with you. And I would say that I don't see a downside to Ologen other than the cost. If I could use it for every filtering surgery, I probably would. I think that it's got some really good characteristics in terms of how it improves wound healing, both by the mimicry of natural tissue and also by diffusing the aqueous over a larger area. And this helps for hydrostatic forces to be spread to reduce hyperencapsulation and tissue cellular overreaction. And I also think that in revision surgery, I think Andrea Fernandez from Uruguay asked about revising in focus, pressure flow surgeries. And I think it's a great way to basically open up conj, remove the scar around the implant, for example, put Ologen down and close on top of it. But I always use mitomycin C. I don't think Ologen can completely get rid of mitomycin C. So I use both. And you can argue, if you use mitomycin C, do you really need to use Ologen? And I don't think the answer is fully there, although there are some studies that do seem to imply that, that the addition of Ologen provides some additional benefits. So, you know, we'll see, but I love it. What do you think, Emilio? I love it. Honestly, I think it's great.
I've been using Ologen for the last 4 years, and the rate of needling is decreasing, and the bleb formation is beautifully better than the past years. So I agree with you, and only, for example, you must use mitomycin together. Ologen by itself does not support a good bleb formation, but you must use mitomycin together.
Yeah, I agree. And again, I've learned from you, my friend. I've learned from you because you were using Ologen for some time, and now I've been using it for a couple of years, and I think you're right on the ball there. As far as your last thing about MIGS and advanced glaucoma, this is the problem with definitions, because, you know, we say it should be used not for advanced glaucoma, shouldn't be used in advanced glaucoma, because the feeling is, well, the pressure lowering may not be enough for advanced patients. However, and that is not untrue. However, in patients, for example, who are controlled and doing cataract surgery and they have advanced glaucoma, why not add something like a MIGS procedure that can get patients on less medications? Even if the pressure is not necessarily you know, as profound as a trabeculectomy, because that patient you probably wouldn't do trabeculectomy for, but you can do phaco plus stents and reduce medications. So if the goal is to reduce medications, it can be used in any severity of glaucoma. If the goal is to get the pressure down to 10 because medications are not getting them down to 10, then that's where I would say MIGS may not be enough, possibly. So I agree with you. I think what you're saying is that don't look at the severity of glaucoma to completely rule out using MIGS, because it's really not based on that. It's based more on what is the target pressure. And the most important variable for me, I should say, and I'm just going to put this slide up here again, Alberto, if you don't mind. But the most important thing for me when it comes to choosing a procedure is whether the glaucoma is controlled or not. Everybody here whose patient comes to see them in the office, the most important thing you need to do is ask yourself when they leave the office, is my patient controlled or not? I don't care about severity. I don't care about the pressure. What do I know? Are they controlled or not? And there's different ways to describe controlled. Remember, another thing I also say is, please don't write stable, because glaucoma by definition is not stable, right? It's always under threat. So it's a false sense of security when you write stable glaucoma. You can write down no progression noted. You can write down IOP in the office is at target. You can write down the patient says they're compliant and they're tolerating it, but you can't write down the patient stable. You can't write down the patient not progressing in terms of at the molecular level. You can't write that down. So that's the first thing I do. Once I decide if they're controlled or not, at that point, then I can decide, you know, where to go with my procedures. And that's, I think, a matter of how I differentiate whether I would do a MIGS or not. If they're controlled or I'm near control, then I think MIGS is completely reasonable. If I feel that they're not controlled and I can get the pressure to a level that they're going to be controlled with MIGS, like 15 or 18, great. So an advanced patient who's not controlled on medications, no, MIGS is not going to be an option for me.
Yeah, I agree with you.
Right?
Yeah. Thank you.
Well, thank you, Emilio. Always good to share ideas. This is how we learn. And I heard Emilio talking about Ologen many years ago, and now we've adopted this. So thank you for sharing your knowledge and experience.
Thank you.
Oh, Ike, we have Matt here with us.
Matt Schlenker, one of the boys.
Matt Schlenker is here. Maybe
put him online. Get him on.
Maybe he can share some preliminary data on his MIGS study. Yeah,
let's get Matt on here. Matt was one of our fellows. You see Matt Schlenker, the name published a lot now in our group, and he's Matt. Where are you? Are you here, Matt?
Matt is not here anymore.
Matt left us. Okay. Well, Matt.
He ran away.
Is he here?
Nope.
Okay. Forget it.
He was here.
Matt sucks. He's a terrible guy. He doesn't know what he's doing. He has no statistical knowledge. He can't write papers.
Hi. What's your routine preoperatively? Like, do you make any washouts? What do you use before surgeries, like any MIGS, or what's your routine?
If I could have my way, I would wash it everybody, including trabeculectomy, because medications confound the result. It's hard to know what the result is when patients on medications, number one. Number two, medications are harmful to the eye with the conjunctival toxicity and irritation. And so I prefer if I can stop them. But the reality is we can't often because the pressures will get out of control. I do sometimes put patients on Diamox and take them off drops before going to conjunctival surgery, because going in to conjunctival surgery, like blebs, when the eye is red and irritated, is a bad idea. It's also a bad idea to operate when the eye pressure is high too, because when the pressure is high in the eye, then it's likely that the cytokine levels are also going to be higher as well, and that can cause more failure. So it's a balancing act. I think Diamox is a good choice. With mixed procedures, you're not as worried about typically. We don't know, but we don't think we're as worried about some of these issues with aqueous. But of course, convenience-wise, patients are a little reluctant stopping their drops. For our clinical studies, we stop the drops. Then we have a better idea the true level of their trabecular meshwork dysfunction. Because what I want to know, ideally, is how good is or how bad is trabecular meshwork outflow. That can give me an idea then in terms of what to select in terms of the procedure as well. But to answer your question, the reality is we don't wash out most patients because of practical reasons.
Box.
Someone also meant, oh, sorry, this is Tiziana. Tiziana's writing.
Sorry.
Tiziana's writing down in the on the chat group. So Tiziana, of course, as you know, is one of our fellows from Brazil. She's been presenting a lot. She was presenting yesterday and also presented at one of our other webinars, actually. So thank you, Tiziana, for writing in here. She's from Fortaleza. She told me Fortaleza is the best people in Brazil. She told me everybody else is not so good. I don't know, but I don't know.
They have beautiful beaches in Fortaleza.
I heard the beaches are terrible there.
Ike, and what's your anesthesia? Or me?
Yeah, you know, I mean, I would probably say that 98% of the time is topical anesthesia, topical. Like for the trabeculectomy I just showed you, it was topical. That patient didn't even need subconjunctival lidocaine because they were comfortable. But I do have lidocaine on a cannula to squirt under the conjunctiva if they're bothered by it. For mixed procedures, it's topical. I don't even think they need to have intracameral lidocaine, although we often use it. But I would say if you're not sure, then I think a block is quite reasonable. Subtenon's block is fine to use if you wish. So I think those are all potential options. I'm reading more of these questions here. Gonio lens. I like the Swan-Jacob lens. Swan-Jacob, man. Swan-Jacob lens is a lens that has a handle, which is not on the left or right side. It's basically right in front like this. So when you do the procedure and do MIGS, if you watch my hands here, basically it's right in front of you. So you can hold your right hand or your left hand, and you're not from the side. I find like it's like when you do this on your head, you're trying to go on your head and rub your stomach. Like it's hard to do that, right? But it's easier when everything is lined up on the front of you. So if you have your hand in front of you like this, holding the Swan-Jacob, and your lens like this, and your hand holding the implant or the microforceps, it's just easier. So that's what I just call it. Swan-Jacob. It's an obviously old lens, but it works great for me, and it's a small footprint. It doesn't take up a big size on the eye surface as well.
Yeah. Ike, JC is asking, I hope it's not Jesus Christ asking here, but he's asking about ACP and angle procedures. What's our experience with it?
Yeah, that's a good question. I didn't really mention that, and I should, because we do use ECP particularly with angle closure, because an angle closure, what's nice is that basically it can help to bring back the ciliary processes, and that can really help open the angle up. Now I realize again that is not necessarily a common problem necessarily, but in some of these eyes which have a high iris insertion, doing ECP we find can actually help to bring the ciliary processes back. But ECP originally was designed, of course, to lower pressure by reducing aqueous production. And it does lower it, but to do it effectively, you have to do a lot of ablation. You can't just do a small amount. So you have to do a good 300 degrees or so, in my opinion, and really paint the process back and forth. And when you do that, you do tend to get maybe a little bit of inflammation and a potential risk for CME. So I think the control is very important. And so when you combine it now with an angle procedure, you now have an outflow procedure, and you also have ECP. I think that it can be an effective procedure to do. It may buy you a couple of millimeters of more mercury, possibly, but also at the same time, you do potentially get more inflammation and a risk for CME. So this is kind of a balancing act between the two. But I think it's actually not a bad idea. And I just don't do a lot of it to kind of tell you about combining them. I like to kind of do one thing and see how it works. And so I don't often combine them, but I do ECP on its own, like I said, more for angle closure. Someone asked about preservative-free drops. Yeah, preservative-free drops I think are definitely better than preserved drops. But even the molecule in the drop, whether it's brimonidine or whether it's prostaglandin, that can be a source of a problem on its own. But yeah, preservative-free is definitely preferred.
Another question here is from Momema Ahmad. She's asking about what make you dilate patient for that when you're doing forgot? What do you make? What's your routine?
I understand.
You dilate it first or you dilate it after the GAT?
There's a big myth, and by the way, Matt Schlenker's here now. It looks like he got a haircut and shaved. Damn. So I'll get Matt involved in a second. But there's a big myth out there, and the myth is to do angle procedures or look into the angle, you need to use pilocarpine or constrict the pupil. You have to constrict the pupil. If you dilate the pupil, you can't look in the angle, and that is completely nonsense. Completely nonsense. Anybody wants to argue with me, go ahead and argue with me, because when you're in the eye, you have viscoelastic in the eye. And you got that chamber deep, you got the angle opened up, and you're completely fine. I even do mixed procedures in angle closure eyes before phaco when the pupil is dilated, and it's not a problem. Occasionally, when you have a really, 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 really shallow chamber, yeah, you got to wait till you remove the lens. But there's no reason you have to basically be a problem for dilating the patient, or you have to constrict the pupil to do MIGS. If you're doing that, you do not need to do it, trust me. So Alberto, we had a couple of things about
Matt.
Let's get Matt in here. So I was just talking about Matt. Matt Schlenker is here. Matt's a faculty at U of T, is in our group as well, and he has his background actually, but believe it or not, an interesting story. He wanted to be a huge billionaire, okay, and he basically did his initial training on Wall Street with these big firms, McKinsey, and he was like he knows how to analyze stocks and everything else. But you know what? Something happened to him where he said, you know what? I have a greater calling, and that calling is to be a glaucoma surgeon who can analyze data and present results and be innovative. And so I was fortunate for him to be a fellow with us a few years ago, and now he's a colleague of mine, and he's published with us. So Alberto, why don't we throw some questions to Matt? Are you there, Matt?
Yeah, man, good to see you here. Good to have you here. So
the only negative about Matt is he's a PC guy. That's the only problem with him.
PC guy. That's he's having trouble with his PC. That's true. And Matt, could you share with us some preliminary data on your MIGS study, or you can't?
Sure. So thank you for inviting me, Alberto, and so yeah, all I heard there at the beginning was Ike was talking about a haircut and a shave. So that's interesting. Maybe that's foreshadowing something. I don't know what's going to happen over there. But I also heard he had some flattering things to say about me earlier, which I appreciate. And all the things he just said are mostly not true. But I don't know exactly what you guys discussed before, but we pretty much exclusively moved to hemi-GATs as opposed to 360-degree GATs. And you're right, we don't have a lot of good data to suggest that we should do that, but the rationale is a few things. One is that we probably don't need 360 degrees of TM outflow to achieve reasonable IOP. Probably 180 degrees, if not less than that, is enough. Whereas by doing 360, we are adding extra risk. We have a chance of going suprachoroidal at some point. We have a chance of causing a retodialysis, If we're doing viscodilation, you can cause a decimase detachment. There's a greater chance of heme for all those reasons and more when doing 360. So I do think that at least our preliminary results, if not data, suggests that 180 for most patients is going to be enough. Basically, if it's going to work, 180 is enough. Then we have the next question, which is, if we are going to just do 180, should we do the inferior or superior? And this too, I think I could go either way. The reason I would want to do the inferior is that we think that the inferior nasal quadrant is where we get the best flow. And this is from more of a basic science approach. So why not include that inferior nasal area in your GAT? The downside with doing inferior is that we know that some of our patients have heme, though I have to say that our heme rate has gone down with some intraoperative and early postoperative management, which includes making sure the eye is very firm at the end of the case, and also leaving some viscoelastic, as much as 20 or 30% of viscoelastic. And again, you can titrate that depending on how much heme you had during the case, and also how worried you are about having a spike. For instance, if I have a young uveitic with a pressure of 45, what's another day or two of having a high eye pressure to prevent heme? I think it's very justified, especially if they have mild disease. But anyway, back to the heme, I think that when you have heme inferiorly, that's going to precipitate PAS in exactly the area where you made your GAT. So that would be a rationale for doing a superior GAT, I think, is that you're going to avoid that, that PAS secondary to the heme. I think Ike and I have been a little bit different in this. I think Ike, correct me if I'm wrong, has been doing mostly superior GAT, where I have completely been arbitrary in doing them. I'm just doing them by whether it's a right or a left eye. So patients who have a right eye, just because I'm a right-handed surgeon, and all of our fellows, except for one right now, are also right-handed surgeons, it's just easier to do a superior GAT. And then for the left eye, it's just easier to do an inferior GAT. And the other thing in the back of my mind for someone who likes to do studies is this is almost a randomized trial, because I don't think right eyes versus left eyes should do any differently. So we're essentially doing a trial, and we can look at these results. And I can tell you, Alberto, from a preliminary, I don't think there's a huge difference between the two. So time will tell whether it's worth choosing, either the inferior or superior. But for now, I'm going to kind of continue to be reasonably arbitrary in how I'm doing it, and then study it.
Yeah, I think the only thing I'd add to that, I think I take kind of a compromised approach where I say that, when you're doing your goniotomy, do it in the infranasal quadrant. So, and therefore, when you do a 180 goniotomy, you're not quite doing fully superior. You're kind of doing like, infranasal and going across into the supratemporal quadrant. So it's 180, but you're incorporating a bit of that inferior angle, because I think that infranasal area, as we said earlier, does have a higher preponderance of these aqueous veins. And so if you do open up the area in that, you potentially may get a better pressure lowering, but you also take advantage of opening up the supranasal angle and the superior angle, because if the blood does get down there, then you still have the other angles open. So to me, it's kind of the best compromise. I don't know if it's better or not, of course, but if you're going to do 180, I think I would incorporate the infranasal quadrant and go all the way across supranasal. So it's not between 3 and 9. It may be for example, maybe between 7 and 1 o'clock, for example, as one example, right? So that's kind of one variation for 180 trabeculotomy.
Yeah, good tip. Good tip. Sebastian Cronenberger from Brazil, my boss. You wanna ask a question?
I'm also wondering, could we have Bruno here too? Bruno, are you a 360 guy or are you 180 guy? Are you the glass half full or the glass all full?
Okay. Hi.
Hello.
Could you give me some information about the long term of the different types of surgery, MIGS?
Sure. I'm going to first answer that question. The question to answer, first of all, is do we have good long-term data for any glaucoma surgery? And the answer is we don't. Even our trabeculectomy data is highly confounded, variable follow-up, selection bias, all the other problems of the large retrospective study. So we don't have good data on any surgical study, number one. That's the first thing I'm going to mention. The TRAB versus TUBE is a TVT study. ABC study is 5-year data. It's our best quality, longer-term data, but 5 years in a lifetime of a patient is a very short time. And that data we have, of course, 5 years. That's the second thing I will say. For most of the bigger MIGS studies, we're getting 2-year data. We're getting usually 3-year data at follow-up. For example, with the Hydra study, we have about 90% plus retention at 3 years, and probably we'll have similar amount, I hope, at 4 and 5 years, because we are being very proactive at following patients up. But of course, patients get lost to follow-up once we get finished with the study. We do have some number of retrospective studies looking at 5-year plus data from Spain, for example, with iStent and other approaches as well. Our Japanese colleagues have published longer-term data with aberrant trabeculotomy, as well as Americans and Europeans as well. So, but as you're going to see, though, most of it is kind of, case series and reports, non-comparative, and with a high amount of attrition over time. And so when you have 100 patients at day 0, you do, and then after 1 year, you have only 70 patients to report. At 5 years, you only have 30 patients to report. I mean, is that really valuable? I can publish a study that shows I have 10-year results with trabeculectomy, and I only report 20% of my patients at 10 years, and I publish it, and it sounds like I have a 10-year study because the title says 10-year study. But that's a big problem we all face, and I think we have to admit that that's a weakness of ours. I think we have to do some extrapolation. We got to do the best we can to try to do together these things. I think if we make a better effort as a society, as a group of surgeons, to say, listen, we're going to take a group of patients that we think are going to be able to follow up and follow them very closely in a registry and not cherry pick and follow them up. I think we can potentially have a better idea. But you've identified a major weakness, and it's a weakness that our government tells us as well. They tell us, listen, Ike, you want to fund this particular device? Well, show me 10-year studies, show me quality of life studies, and we don't have those kind of things. So that is a weakness we have. Same thing exists, of course, for drops. We don't have any. It's hard to get long-term evidence for drops, but luckily we have some big studies now that have been published. EMGT, for example, is one. SIGIS and other studies that kind of give us some information. So that's what I would say. I should mention SIGIS is another good study to look at as well, of course, for trabeculectomy.
Yeah, we need to tackle the rate of progression, and lately, of course, the quality of life. So, Bruno, want to share something about your, as a 360 guy?
Hey, Ike.
Hey, man, good to see you, buddy.
Thanks a lot to come here, share your experience. So I'm 360 guys. So every time I try to do 360. I think sometimes we feel some resistance in the Schellem's canal. In this time, I did 180. So when I did 180, I always do superior.
Mm-hmm.
But every time I tried 360.
Would you be willing to do a study with us? Bruno, I'm going to try to convince you to be part of the study.
Yeah.
Oh yeah, will be a pleasure.
All right, man. Look at that, Alberto. You're bringing studies in here, and Matt's already the man on it. So
yeah, let's recruit a center here. That's
perfect.
it.
Ike, we are planning to we are starting doing a study in Brazil, a multi-center study about GAT versus TRAB. So let's see what's going to come.
GAT versus trabeculectomy?
Yeah.
Okay. So I can tell you the result already.
Yeah.
Please. What's your opinion about it? About the result?
Save us some time.
Make a spoiler.
Well, I don't want to be a spoiler, but I mean, I think and let me ask you: are you using Vitamize to see what trabeculectomy?
Yeah.
Yeah. So I mean, it's kind of cheating, though, right? Well, I mean, it can probably inform you. It can inform you because I don't think this kind of study has been done in Brazil, number one. So you can inform you on data is good, but I mean, it's going to be hard for. And I don't know what your main outcome measure is. What's your main outcome measure that you're going to be looking at? Are you looking at like what is the main?
We are doing just that. What's the results? We are only drawing the study. We didn't start it yet.
I think only IOP and medication.
No, IOP, medication, and a number of complications too.
Okay.
What's our idea here in Brazil at this time is that GAT can be a procedure you can use before sometimes when you think about a trabeculectomy, you can use GAT, and at least you win some months or some years before you make a blab on the patient.
Yeah,
that's what we want to know about it in public health system. What is the impact?
Yeah, I mean, I guess it's a big discussion to have. I mean, whenever we do a study, we want to compare, we want to have a proper comparison, right? You know, and already what you're saying, and I agree with you, I think GAT can be used before trabeculectomy. So it's really not really a head-to-head comparison, right? It's not really, what I think the best comparison probably is medications, for example, right? You know, that's kind of probably the better comparator, or trabeculoplasty or something like that, because this is always a challenge because MIGS doesn't really compete with trabeculectomy. It's not supposed to. And MIGS, I guess you could argue maybe competes with SLT, but really doesn't necessarily have to, because SLT can be done easily, or trabeculoplasty, and you can do MIGS after. So it kind of fits into this, in this new area. And we want to have a comparator, but we struggle with that comparison because what do we compare to? So medication is really, to me, is like whether you're going to add 3-4 medications or whether you're going to go to a GATS. That's probably the best thing. But I think what your study will inform you will be that you can say, listen, and this is why it's important, your inclusion criteria is proper. Severity's got to be proper. But you may be able to show, listen, we were able to avoid trabeculectomy in X% of patients. However, the success rate was lower than trabeculectomy. And then, you know, you'll be able to sort of, you know, use that in that context. So that's what I would say. I mean, it's just a difficult comparison to make because they're not really apples to apples, you know?
Yes, we know that. But what do you think about, we have in Brazil, in the public health system, you can use the other MIGS. They are very expensive. Yeah. So when you use GAT with the Prolen, it's very cheap. And you don't have the bleb, all the problems with the bleb. So most of the time we made some decisions about making a trabeculectomy, about the problems with the patient, with the eye drops and a lot of other things, the prep. Almost the time we make the decision about doing a trab on the public health system, only based on the IOP. So that's a problem for us. Maybe GAT could fill a place here before you make a trab.
There's no question GAT will. I mean, for an area where you have an issue with cost and budget impact, a 5-0 proline suture, a 25 gauge needle, and viscoelastic and a micro forceps or something is perfect. And I can tell you that you're definitely going to be able to avoid doing trabeculectomy in many patients. Remember, I mean, a GAT could get you down even below 15 in some cases, you know, and with medications can get you in that range as well. So I think that's fair. But I mean, I think you can probably prove the same thing you're trying to prove by simply doing a very well-designed prospective study that follows GAT patients for 2 years, and you can show the results of what to do, and not do it with cataract surgery. It should be standalone. Yeah. And therefore, you reduce that confounder, and you wash out patients. And, you know, I think you could really do a nice study with that. But I think a trab comparison, listen, it's going to inform you a bit, but it's a hard comparison to make because trabeculectomy is going to win. If IOP is your main outcome measure and medications and some sex rate, then trabeculectomy is going to win. We know that, right? Maybe, and the safety part of it may not be enough recruitment to show a difference in safety in the short term. So,
okay.
That's what I would say. But I think listen, I'm always good when anyone does a study. It's always good that you're thinking about it. So, and I'm sure Matt probably has opinions on this as well. But I think, you know, just be aware of what you're going to get. And when you want to publish it, what you're trying to show, you know?
Yeah, perfect. Thank you a lot.
Ike?
So,
hello.
Ike?
Clarice.
Oh, yes. What's your favorite surgeon on small eyes?
My favorite surgery in small eyes?
Yes.
Well, it's phaco.
Phaco.
Oh,
this one is easy.
Yeah. Mine too.
Ike. So Marta Pacheco.
Sorry, I didn't answer the question.
Yes, you didn't.
You're probably saying the patients had phaco already.
Yes.
And the pressure is not controlled.
Yes.
Yeah. So I mean, I think a couple things. I mean, if the angle is open, and you believe you can do an angle procedure, I think that's appropriate, again, depending on what your pressure target is. So I think that's fine. If the pressure target is not going to be obtained with a MIGS procedure, then I would go subconjunctival. And in those patients, I typically, again, go back to my subconjunctival MIGS, whether it's Zen or pressure flow. But whatever I do, I'm always making sure it's combined with cataract or it's after cataract surgery is done. In very rare situations, there's probably an argument to be made to do, for example, a vitrectomy, a full vitrectomy, and put a pars plana tube. That I know that sounds very aggressive, but I think for some of these really, really bad eyes where they have no anterior chamber, sneaky everywhere, bad corneas, and a pseudophakic, some of them are around, I think the best option is to do a full vitrectomy and put a pars plana tube in, like a bare-valved or non-valved implants.
Okay, and if you need to do a vitrectomy, you will do before the phaco or later? You do the phaco in the vitrectomy anterior eye or no?
Well, I guess maybe it's a few different questions on that one. If I need to do vitrectomy to create space in the eye to do the phaco, then I sometimes do that. Although I'm really careful doing vitrectomy in small eyes because, again, as I said another day, the ora serrata to limbus relationship is quite distorted. Normally, we can say the aura is 5-6 millimeters back from the limbus, and we can make a trocar entry 4 millimeters or 3.5 millimeters or 3 millimeters back from the limbus. But in these very small eyes, the retinal insertion may be 2.5 millimeters back from the limbus. So where do we enter from? So if I have a 16 millimeter eye, boy, I'm really worried if I make a pars plana incision that's going to happen. So first of all, if I'm doing a big vitrectomy, I'm going to have the vitreoretinal surgeon doing that. And secondly, I wouldn't need to do it unless I couldn't form the chamber in phaco. And usually if I cannot form a chamber in phaco, it's because the patient has either a uveal effusion, which I can drain, or they have a choroidal detachment, or they have malignant glaucoma. All of those can be treated without doing a full vitrectomy, you know. So, but those small eyes, yeah, I'm going to be giving a talk, I think in a couple of weeks on nanophthalmic and glaucoma, and that's kind of the things I'm going to talk about. But those are, yeah, and I'll tell you, those are not easy. Now, the last thing I'm going to mention is that sometimes, honestly, like cycloablation is the best answer, you know. And in an eye, for example, that has pseudophakia and pressure is very high, and you don't want to do vitrectomy and everything else, then doing a transscleral micropulse is not a bad idea. It's not a bad idea. Just make sure you know that the anatomy again is a bit altered. You got to go fairly anterior, right? You know.
Okay, thank you.
Good question. Tough question. I was trying to get out of it.
Okay, Ike. Another procedure that's becoming very popular here in Brazil is the micropulse laser treatment. Yes. And my question, and my former glaucoma fellow Marta Parshin, that now is in Barcelona, is the same question. Where is the place you put this kind of treatment in your glaucoma algorithm treatment?
Yeah, I'll be honest with you, I'm not sure fully. I mean, it's a tough one because I'm generally not the biggest fan of, ablating tissue. And I still believe micropulse is somewhat destructive. It's using heat. You need to block the patient or give them anesthesia to really do it effectively. And so that's the first point. On the other hand, it does, of course, seem to be gentler than regular cyclotransscleral G-probe ablation. ECP also is a gentler approach as well, by the way. And I think for me, I don't feel comfortable doing this procedure early in glaucoma, for example, not yet. I feel there still are some rare problems that can happen. Inflammation, atonic pupil, CME, number one. Number two, sometimes you can damage the conjunctiva, which can make it difficult for further surgery. And number three, cataract formation is still a question mark. So for me, I don't usually place it early. I do think it's got my sweet spot for this procedure would be someone who already had a bleb. They've already had filtering surgery and the pressure is not best controlled. Then rather than adding medications or rather than going to more surgery, then I would think about doing micropulse there. To me, that's probably the best place for it right now. Does it replace MIGS for me? No, I'd rather do outflow procedure. Does it replace medications? No, I don't think the safety of it I feel comfortable with. And also the other fourth problem is, like, there's a high retreatment patients need to be retreated after 6 months, 8 months, often in my experience. And we haven't optimized the settings, and there's so much variability in it. So it's early days. I think we need to be open-minded and think about it and learn more about it and get more experience with it. But still, nevertheless, I mean, it can lead to potentially some long-term issues. And I have had patients, for example, I've done Zen or PreserFlow with, who had micropulse. And guess what? Those patients had some hypotony. And why? Because we make these devices controlled based on normal aqueous production. And these patients can have chronic aqueous production issues. And I think that can lead to potential problems. It's the way it works too, which is good. But then we need to do something else, then the fluidics and the physics of outflow then can be altered. So there's just some things that I'm not comfortable with. And I know I'm somebody, I guess people think this guy's pretty progressive. He does lots of new things.
No, it's because it's easy. It's easy to do.
Yeah, just because something's easy doesn't
I used to
mean
it's surgery for R1 resident. It's very easy.
Well, that's not a bad point to make, especially if only R1s are doing the glaucoma procedures. Then I get that. But the idea is to do something that is something that everybody would use with a greater skill set. But it is a good point, because one of the problems with MIGS is the skill involved in it.
Yes.
One of the problems with even doing Zen and PreserFlow is the skill involved in it. And even for, not forget residents, even for seasoned surgeons, it's a problem for them. I'm going to admit, we don't want to talk about it, but it's a problem. And that can really limit the results. And again, I gave the example with phaco. Like, people had a hard time with phaco, and people said, listen, a resident can do an intercap, and great. But then eventually phaco became the norm for many reasons, as I mentioned earlier. So ease of use is only part of the rationale to do it, though. And that's kind of my question. Oh, here comes trouble.
He's back.
Here comes trouble.
Yeah.
She beat me up already once.
It's time to end, Alberto.
Yes.
No, it's okay. It's okay. We got the rest of the evening, but I want to make sure we.
No, you said she could come back in 30 minutes. That's it.
I did say that, didn't I?
Yeah.
So
we
Ike,
all have children.
Ike,
Yeah.
we all would like to thank you for sharing your knowledge with us in this hard time period that we're passing through. Okay, and there's a nice view. We almost it every day with all the kids. Okay, so say hi to Sophie, and lovely Sophie. Okay, and we need to schedule a number two meeting.
Yeah, well, I think
Yes, please.
I have one question, Alberto.
So Homero will kick a quick last question.
No problem.
Okay?
I give
the last one. It's the last.
Kept her busy. Don't worry.
Ike. It's very nice to have you with us once more, and you have answered most of the questions I had. But there is one I would like to know: which gonio lens you prefer? The ordinary, the plain one, direct view, or the Ahmed double mirror lens? I'm not listening.
Sorry about that. Sorry, I just had to go on mute for a second. Yeah, so I would say that for MIGS procedures, my best view is still the Swan Jacob. The prism and the view you have is the best. But I will say that the double mirror, the DVX lens that I showed earlier, which has my name on it, again, I don't have any financial interest in it, is definitely coming close to it. It's definitely coming close to it. But you have to remember that when I'm in Swan Jacob, my hand's like this up in the air. On the other hand, when I have to do a DVX lens, my hand's very flat. And so you have to remember your hand position changes. But I do think that the future, I believe, is moving away from the prism and more toward the double mirror lens, which I've designed, which took, by the way, 6 years to design. It's not easy. It wasn't easy at all. To get the wide field of view, the problem with double mirrors two mirrors are you lose light, you get minification, you lose quality because of the light bouncing off mirrors. So I pushed the optical engineers so hard, they were mad at me, so hard to enhance the field of view without losing too much light and to use the right optics and the right finishes to reduce the aberrations that occur in the loss of resolution. And we have a lens now that now is very expensive, unfortunately, because of that process. you know, right now though, I think the Swan Jacob is comfortable for me. That takes a bit more time, but the future to me, I think, is a DVX lens. That's what I'll say, something like that.
Okay, thank you.
I don't make any more money from that. I only make money. I
You-
only make
you
money on
should
the
have.
Ahmed valves. So keep on putting Ahmed valves in, right?
You should.
So Ike, nice to have you here, man, in the Glaucoma Zoom meeting. Okay.
Well, thank you. I want to thank you, all of you. I mean, I see a lot of nice, happy faces here and great people. I do miss you guys a lot. Brazil has really been wonderful to visit and to be with. Not because of the country necessarily, but because of the people. Well, country too, but the people, man, it's amazing. And Alberto, just a personal thanks to you for your friendship. As I said earlier, you're a brilliant guy, very smart and well accomplished with your publications and your research work. But most importantly, as a human being, man, you're such a warm guy. And I just missed that big hug when I came to Belo Horizonte in November.
All about people, man. That's it.
It is. And
Life
it's
is all about
exactly.
people.
It's about people. If we do it for people, it's the best. It's the best thing for people, our patients, our colleagues, and even though we're stuck in our own homes, we make great connections. It's amazing the connections we can make from people, because you don't have to hear somebody. You don't have to even see somebody. You don't have to even be with somebody. But when our spirits and our souls are connected, man, that is like powerful. So God bless, peace to everybody, love everybody. And I'll see you at the next webinar.
Thank you very much.
Thank you all for being here,
Thank
and all stay safe.
Thank you a lot.
Stay well. Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye.
Emílio.
Vianello, você vai comparar gato com treco, você vai se dar mal, vai queimar o gato.
Meu objetivo não é ganhar dinheiro em cima de nenhum dos dois.
Não, né? Mas é minha opinião, mas o treco vai baixar muito
Eu vou
mais.
comparar gato com o quê? Com faco?
Ah, eu acho que a gente tem que pensar direitinho aí. Foi o que ele falou.
Lógico que não, só tem um jeito de comparar que é gato,